just share with you all. And I just learned how to do this, so I'll just get it on the PowerPoint. Okay, so in this presentation, what I'd like to do is present a review of upper extremity neurodynamics. And included in this, my goals for this presentation are to define what we mean by neurodynamics, to review a nerve root versus a peripheral nerve lesion and what those different localized lesions may present with, what deficits those lesions may present with clinically. I also want to review a little bit of brachial plexus anatomy, not super in depth, but enough so that we have a sense for the courses of these nerves, and especially the main three nerves that supply innervation, motor innervation, and sensory as well to our upper extremity below the shoulder. So median nerve, ulnar nerve, and radial nerve. We're going to go a little bit more in depth on those. And then review clinical upper extremity neuro testing for nerve roots, which ends up being what we're familiar with as a neuro screen, but then also peripheral nerves. And these are going to be our upper limb tension tests primarily. There is going to be a little bit of special tests that I integrated in here, especially for those three main nerves that we're going to talk about. So we'll discuss that a little bit. So here we go. All right, so why use the term neurodynamics? So neurodynamics has been defined as the study of mechanics and physiology of the nervous system and how they relate to each other. And I think that's really important because we know that nerves are living tissues. Neurons are cells, and they need oxygen, blood supply, nutrients, just like all of the other cells of our body. Nerves, as we'll review, are parts of neurons. So nerves are bundles of axons. So they are living tissues. And because of that, just viewing them mechanically, as is done in maybe more of a neural tension description or framework, maybe misses the point a little bit. In other words, it's not completely comprehensive with the other important factors that affect these nerves, affect the health of them, and maybe, as we'll see, affect some of the signs and symptoms that you will observe clinically due to maybe a nerve sensitivity, nerve irritation. So neurodynamics is really the more appropriate term, I think, as we start to look at the health of the nervous system and signs and symptoms that we are observing from nervous tissue, living tissue. So that's the distinction that I wanted to make, and that's why I will consistently use that term neurodynamics as opposed to neural tension. So why do we care? Upper extremity neurodynamics. So clinical applications. So this is just something to think through. If you have a patient presenting to physical therapy with complaints of arm pain that travels down into her fingers, she may report clumsiness, numbness, or tingling in some of her digits. Not sure how it all happened, doesn't really know the mechanism. You're going to start thinking to yourself that it's important to assess her nervous system. So she's reporting radicular pain, first of all. She's reporting symptoms that we often think of as paresthesias, numbness, tingling. So some sort of nervous system issue or neuromuscular issue that we really want to dig into. And you, as a physical therapist, know that's going to be really important to take her through a comprehensive neuro exam and try to differentiate where in the nervous system her symptoms are coming from, or where she's experiencing pathology that's going to match up with these this presentation. So where is the lesion? It's what we oftentimes think. So are we thinking about a central nervous system issue contributing, peripheral nervous system? Is it a nerve root issue, or is it a peripheral nerve issue? Those are going to be some things that are important in our differential diagnosis for this individual. So that's why, that's what makes it important to review these upper extremity neurodynamics. Quick review, again, nerves, what do we mean when we talk about nerves? Nerves are bundles of axons in the peripheral nervous system. They conduct electrical signals, they depolarize and send action potentials along their length. And I like to think they function kind of like wires. In other words, the information going up or going down is transmitted via electricity. And in order for that nerve to communicate with something upstream, for example, brain, spinal cord, the nerve or the peripheral outlet of that central nervous system information is going to be the wire that communicates information either up to those structures or down from those structures to some sort of effector organ. So a muscle typically is what we think of for alpha motor neurons, but it could be viscera, it could be organs, like what we see in communication via our autonomic nervous system. But I think what's really important is that nerves function as wires in that the communication is very physical. So a nerve has to touch the structure that it innervates to either send information up or send information down. And so as we start talking about and thinking through the courses of these main nerves that we're talking about, I want you to keep in mind that those courses are very important because they affect or they dictate what areas of the body that nerve can communicate with regionally, because that nerve, that wire, has to touch the part of the body that it's bringing information from, sensory data, or taking information to, motor data or muscle control. And so where that nerve is located is of paramount importance. And if you think about it as a nerve, I really think it helps to maybe simplify what sometimes is a little bit amorphous or a little bit confusing. It doesn't need to be that confusing. Okay. So when we start thinking about the nervous system organization, we really want to differentiate between nerve root issues and peripheral nerve issues. So we remember the definition of these two structures, or if we think about differentiating factors, when we're talking about nerve roots, in particular spinal nerve roots, we're thinking about the nerve root, or we're thinking about one spinal level. So these nerve roots are going to exit via intervertebral foramen. And so that could be one potential source of compromise of that nerve root. Could be a narrowing of the foramen or stenosis. And an example of a nerve root would be C8 nerve root. And we know exits below C7 vertebrae. If this nerve root is affected, for example, compression at that foramen, what we're going to see is we're going to see dermatomal deficits, myotomal deficits, and or hyperreflexic or reflex deficit. We could see one, two, or all three of those deficits, depending on the severity of the compromise, or just depending on the patient presentation. In contrast, if we're thinking about a nerve lesion, this is going to happen distal to that nerve root. So the nerve is going to be a collection of axons made up of multiple nerve roots in most cases. Some peripheral nerves will have contributions from only one nerve root, which is a little bit confusing, but I want to make the differentiation by saying majority of nerves are going to have multiple spinal levels involved or multiple nerve roots involved. And an example of this would be our ulnar nerve, which has contributions from C8 nerve root and T1 nerve root. And we know that, and we see that very commonly, as the ulnar nerve is the terminal branch or the distal branch of the medial cord of the brachial plexus, which we'll see visually in a second here. And if peripheral nerves are affected or involved, what we're going to see, instead of these localized stripe-like patterns that are maybe dermatomal or myotomal, peripheral nerve deficits tend to be regional. So they tend to be a regional area. We can draw a circle or an oval within that nerve distribution. And if we remember our wired analogy, this is going to reflect the fact that there are multiple branches from those peripheral nerves. And so we're sending wired information into a broad territory, not just one stripe like a nerve root. So quick review of nerve roots and nerve root levels. We have 31 pairs of spinal nerve roots. In other words, nerve roots that exit the spine. The reason I keep saying this is to differentiate between cranial nerves, which we're not going to talk about in this presentation, but remember that they exist, and you can go through and review those on your own. But spinal nerve roots are going to exit from the spinal cord. And so in the cervical spine, we have 8 of those. We know that the cervical spinal nerve roots, C1 through C7 are going to exit above the vertebral body of interest. And then with the C8 nerve root, because there are only 7 cervical vertebral levels, the C8 spinal nerve root is actually going to exit below the C7 vertebrae, and that's going to set the trend for the rest of the spinal nerve roots. So within the thoracic spine, we know that T1 through T12 spinal nerve roots are going to exit below the vertebral body of interest, and that's going to hold true all the way down. So 12 thoracic spinal nerves, 5 lumbar, 5 sacral, 1 coccygeal. So just a quick review of those levels and where they exit. And as we're looking at our clinical nerve root testing, this is going to be what we commonly think of as our neuro screen. And there are 3 parts to this comprehensive neuro screen. So we want to test sensation, or we want to test the ability of that nerve root, its sensory data, so ability to send information from the periphery up. We want to test the ability to send information down, so our myotomes or our muscle testing, motor information, and then we want to test the integrity of the reflex arc. What we tend to see, and this is a little bit of a nuance, is that as nerve roots are affected, they're going to progressively affect these areas according to the severity of the lesion. So typically, this is not always the case, but this is a pattern that we typically see clinically, and it's commonly described in our physical therapy texts, is that in a less severe nerve root lesion, the first thing that will be affected will be sensation. So a less severe lesion at a nerve root will cause paresthesias, typically numbness, tingling, sensory loss. However, there will be no strength deficits, and reflexes are going to be intact. Progressively, as that compromise is greater in severity, for example, the intervertebral foramen has been affected, maybe it's stenotic, maybe it's so that space has been narrowed, putting pressure on that nerve root, we're going to have progressively increased deficits. And what that might look like is now, instead of just having some sensory deficits, now we're going to start seeing motor deficits or muscle weakness. At a more severe level, when your nerve root is even more compromised, that's where you're going to start to see reflex deficits. So that's something to keep in mind. And that's why I like ordering it this way, dermatomes, myotomes, reflexes, is you can start to think about what is the severity of the lesion. Even though it doesn't always follow that pattern, it is a good pattern to keep in mind because that can sometimes guide your assessment of a treatment or referral decision, or just trying to think about your ability to affect this patient's symptoms. In a severe stenosis, where somebody has reflex loss or rapid progressions through these 3 areas of deficits. So you see them on a Monday and they have sensation loss, and you see them on a Friday and they have reflex loss. That's going to make you think about referring versus somebody who just has sensation loss and you're able to treat and remedy some of that sensation loss from a Monday to a Friday. They're going to be more appropriate for a physical therapy plan of care. So I hope that makes sense. Okay. As we're thinking about testing for nerve root lesions, again, we want to test these 3 different areas. So dermatomes, we want to test sensation, the different dermatomes. Myotomes, we want to test according to the muscle group that's been linked with that specific nerve root area. And noted, there are some overlapping areas between dermatomes and myotomes, so this isn't perfect, but I feel like this is a nice start to try to represent deficits and localized deficits to a specific nerve root area. So this chart that I came up with, and this is the way I clinically will test myotomes, and like I said, there are other muscle groups that can be used to test at these different nerve roots, so please don't take this as the be-all, end-all of myotome testing, but these are just the muscles that I tend to pick out and the sequence that I tend to go through because it makes sense to me. The corresponding movements to these myotome tests, the way I go through this exam, I made a little video, so you guys can check out that video on YouTube if you're interested. That's the link here. We won't go through that because I think you guys are probably pretty familiar with myotome testing at this point, but it's a nice review, what muscles are linked with what level. And then the other thing I wanted to put in here are the reflexes associated with different spinal levels or spinal nerve root levels. And again, there is some overlap. So we know that the biceps reflex, for example, has contributions from both C5 and C6 nerve roots, but if we were to give it one main contributing nerve root, it would be C6. And that's just a decision that has been made and probably validated by research. There's a reason for that, but anyway, that's the way that is. And again, I hope that's not confusing, but that's just the main contributor to the reflex, knowing that there is a little bit of redundancy between these nerve root levels. All right, so testing dermatomes. So sensory information or sensory areas that correspond with these different nerve roots, we describe as dermatomes. So as you go through a dermatome exam or a sensory exam and test these different areas of the body in the upper extremity, what you're going to try to find is a pattern of sensory loss within a stripe type pattern that's going to indicate more of a nerve root lesion. And you can see those laid out here where you have C2, 3, 4, 5 coming down from the neck to upper arm. As you get into the thumb and fingers, so thumb is going to be C6, C7 is typically described as the middle finger, sensory testing on that area. Medial forearm, C8, and then T1 up into the elbow and T2 into the axilla and pectoral region. Thoracic, sensory dermatomes are going to be within the rib cage. And since we're talking about upper extremity, those are our main areas of interest. Lower extremity are going to be your lumbar sacral plexus. Okay, so peripheral nerve sensory fields are going to be more regional. Again, sensory branches from these peripheral nerves are going to have more widespread distribution. And so these colored areas are trying to represent sensory data coming from or traveling along these different nerves or wires, collections of axons to take information back up to the brain, sensory information. A couple I want to key in on are the three main nerves that we're going to come back to in our discussion of upper extremity tension testing and clinical exam. We're going to talk more about the median nerve, which is going to communicate sensory information from the lateral 3.5 digits, so digits 1, 2, 3, and half of the fourth. And then if you look in blue on this field, the ulnar nerve, which is going to communicate sensory information from digits half of the fourth digit and the fifth digit. And then this small little area on the dorsum of the thumb kind of wraps around, and a little bit of the dorsum, you can kind of localize right in that area is going to be the base of the thumb, the anatomical snuff box. That's going to become important. So that sensory area is going to correspond to the superficial branch of the radial nerve. So the radial nerve does have a little bit of sensory information communicated, not quite as much hand territory as the median and ulnar, but it does have some sensory data. So keep that in mind. All right, so as we transition to talking about nerves, sort of nerve roots, what do nerves need? Well, like I said, nerves are living tissues, and so the needs of these nerves to be healthy, happy, not cause symptoms, are that they are going to need space. So we talked about that a little bit with nerve roots. If you have compression or if you have stenosis at the intervertebral foramen, nerve roots aren't very happy. Nerves are the same way. They don't really like compression or sustained compression, so they need space. They also need movement, just like most tissues in our body. Motion is lotion, so we know that our muscles really like movement for muscle health. We know that bones need movement or forces applied to them, compression force to have healthy bones and healthy bone mineral density. And nerves also really like blood. And the reason for that is they need oxygen, they need nutrients, they need nutrition in, waste out, just like our other living, breathing tissues. So keep these three things in mind as we think about health of the nervous system and health of nerves in particular. They need these three things. And if any of these three things is compromised, that's when we start to see symptoms that are specific to this area. So the nerves start to talk and they start to say, I'm not getting my basic needs met please address those basic needs. And the way they tend to do that is with some sort of symptom, pain, or some sort of communicating information to let us know these things aren't there and maybe we need to address them. So like we talked about, peripheral nerves can send, they do send information via electricity or electrical signals, and they're going to send information down, which is motor information, so control of muscles. They're going to send sensory information up, or they're going to send both. So nerves can be of one of three types. So they can be motor only, they can be sensory only, or they can be both, similar to like we think about cranial nerve functions. So you can have cranial nerves that have motor functions, sensory functions, or both. And if we think about sensory only nerve, we think about the cutaneous nerve of the forearm. It's only sensory. It has no innervation to muscles, and so it's only sensory data. If we think about a nerve that is both motor and sensory, we think about the median nerve, which is, like we saw, going to supply sensory data from parts of the hand, and as we're going to see, is going to have contributors to muscles in different areas around the elbow and hand. So different types of nerves, different types of information. Like I mentioned prior, nerves need these three things. If they don't get them, we're going to start seeing signs and symptoms of a nerve lesion. So burning and shooting pain, those descriptors of pain make us think that a nerve may be involved. Those are indicative of more of a nerve pain versus a muscle pain or musculoskeletal pain. Numbness and tingling, paresthesias, weakness, motor loss, loss of sensation, poor motor control, and loss of reflexes could all be signs of a nerve lesion. So those sound pretty similar to our corollaries or our correlates from a nerve root lesion, where we saw dermatomal sensory, myotomal motor, or reflex deficits. So there is some crossover, and that's why we're trying to figure out, or that's why there's a need to differentiate between a nerve root and a nerve lesion. And we're going to try to start to localize based on some of our nerve testing compared with our neuro screen. The positive or negative findings from those two different things are going to help us try to localize these different lesions, whether it's a nerve root issue or peripheral nerve issue. Okay. So if we're thinking about tests that correspond with these different areas, and this isn't perfect, but I think this starts to give you a sense for why nerves need these different functions. So if you compromise space for this nervous tissue, and these tests actually have to do with more compromising that interforaminal space of the nerve root. So the nerve root doesn't have enough space. If you're trying to compress and shut down those foramen with a Sperling's A or B or quadrant testing, so extension plus some sort of rotation or side bend, that can compromise the space that nerve root has to go through, and that can provoke symptoms. So that's kind of a space test, if you will. Clinical test for blood. So why do nerves need blood? We talked about that, to deliver nutrients, take away waste, deliver oxygen. So if somebody has lack of blood flow to these nerves, and that's what's provoking symptoms, we can often treat with ways of encouraging blood flow to that nerve, or encouraging encouraging blood flow to that specific area. If that helps relieve symptoms, then that's a real positive, and that could be because of this mechanism. So if aerobic exercise is going to encourage blood flow, that's great. So upper extremity aerobic exercise to encourage blood flow to the nerves could be a way to remedy some neural symptoms. So could a glider exercise or an active range of motion tension test position, and we'll kind of talk about that later. And then, like we saw, movement can be really helpful or needed for nerves, and we can create movement either passively or actively as part of a treatment. Okay, getting to the brachial plexus. So I know that was a big intro, but little review of the brachial plexus. And what this is if we break it down, brachial refers to arm, so Latin brachium, it means arm, and plexus is a braid or a plate or a network. So the brachial plexus is the main network of nerves that supply our arm or supply our upper extremity. So served from nerve roots from the neck, these nerves travel down into our arm and innervate areas in our upper arm, elbow, forearm, all the way down to our fingertips. So here's a brachial plexus representation. And again, not going to go through this in a lot of detail, but just suffice it to say that there are roots, trunks, divisions, cords, and branches for that brachial plexus. And we know that there's going to be a right and a left brachial plexus, or right and a left upper extremities. Nerve roots from C5 to T1 are commonly described to contribute to that brachial plexus. And the cords contribute to terminal branches or nerves that then supply our upper extremity with information supply, with wired information. So terminal branches from the lateral cord is going to be the musculocutaneous nerve, posterior cord, axillary nerve, and radial nerve, which we're going to highlight. The medial cord terminal branch is going to be the ulnar nerve, which again we're going to highlight, and that median nerve is going to have contributions from both the lateral and medial cords. So these three main nerves to the upper extremity are going to be the median nerve, ulnar nerve, and radial nerves. Made a few charts over the next few slides, and not that I want to read you these charts, but I do want you to have these as references. So the main three nerves are here at the top: median, ulnar, and radial. And then I've kind of broken it down based on the cord that contributes to these different nerves. So again, these are the terminal branches, and these are the cords of the brachial plexus. But then what I want you to focus on are the motor or information traveling down this nerve to the different muscles. So muscle functions corresponding with these different nerves are going to be in this area, these areas, the second or the third row of the chart. And then sensory areas, so data traveling up along these nerves from distal to proximal are going to be in these areas. So we talked about sensory data. Those are pretty simple to remember. The motor data, however, you'll see is a big breakdown of all these different muscles in the arm and forearm that supply muscles that control the elbow, wrist, and hand. And I don't want to go through all of these because, again, you all are more than smart enough to read this chart. I don't need to read it to you. But what I do want to give you is maybe a quick tip or trick to try to remember and differentiate between median nerve and ulnar nerve muscles, because I think the radial nerve kind of stands out given that it supplies the elbow and wrist extensors. And that seems like a pretty easy pattern for most people to remember. So the triceps and anconeus as an elbow extensor, that's going to be radial nerve. The wrist extensors, primary wrist extensors, are going to be supplied by the radial nerve. However, the elbow, well, mainly they're going to be wrist flexors and then hand intrinsics are going to be split between the median and ulnar nerve. So they're going to trade off, or not trade off, but they're going to kind of split the difference between some of these muscles. And so that I oftentimes think is a little bit harder to remember. Here's my trick is, and you can see this in the notes, the median nerve, I tend to think of the median nerve as being greedy at the elbow and wrist. In other words, the median nerve supplies the majority of our wrist flexor muscles coming from that. If we remember, where do our wrist flexors originate? Primarily from the medial epicondyle. And that's why I have elbow and wrist. So they do cross the elbow, but they act at the wrist. And that's what I mean by that. The median nerve is going to supply the majority of these muscles, with the ulnar nerve just filling in a couple, okay? Versus the ulnar nerve is going to be really greedy in the hand. So the ulnar nerve is going to supply the majority of the hand intrinsic muscles, while the median nerve is just going to be a supplementary supply to the motor intrinsics. So median nerve, if you want to remember it this way, this may be the easiest way to remember it. The median nerve is going to supply in the hand the thenar muscles and the let me say this right, the lateral two lumbricals. So lumbricals to digits second and third. And intrinsically, the ulnar nerve is going to supply all the rest. So just remember the ones that the median nerve supplies, and then the ulnar is going to take all the rest. Versus at the wrist, if you think about wrist flexors, the ulnar nerve is only going to supply the flexor carpi ulnaris, that's my abbreviation there, and the flexor digitorum profundus muscles to the 4th and 5th digits. Median nerve is going to supply all the rest. So that's your quick little trick. And I know that took a second to explain, but hopefully that eases your memorization of those muscle groups that those different nerves contribute to. Special testing for these different nerves. And again, I'm not going to read these to you, but I've kind of broken it down based on the special tests that we commonly use to test these different nerves. And then the MMTs for the key muscles are going to correspond with, like we talked about, the different muscles that these nerves innervate. Those MMTs are going to correspond with those muscles, and that's how you can start to differentiate between maybe a median nerve lesion and an ulnar nerve lesion. I might point out a couple, and this isn't perfect, but if you're thinking about forearm pronation as a muscle action or muscle group and a deficit there, we commonly think of that clinically as pronator syndrome, and we assign that to a median nerve lesion or deficit. So there are a few key ones that don't cross over that are very specific to one nerve, and those are the ones that you're going to want to test or be aware of as you start to try to differentiate between these different nerves and what sort of lesion you may have if you suspect a peripheral nerve lesion. Again, elbow extension, wrist extension, if you have deficits there, you're thinking more radial nerve, and we'll see this described clinically. If somebody has a loss in active wrist extension, we'll see that described as wrist drop. So radial nerve wrist drop or radial nerve palsy will present as somebody with the inability to extend the wrist, and their wrist will flop into flexion. So that's pretty characteristic. Ulnar nerve, a lot of our tests for ulnar nerve are going to be consistent with the hand intrinsics. So one example of that is Froment's sign. If you all remember, that is the clinical test where somebody is asked to pinch grip a piece of paper between their thumb, so their first and second digits, their thumb and pointer finger, and that pinch grip or grasping of the paper in that specific way is the strength of that is contributed a lot from the function of the adductor pollicis muscle, or the muscle that adducts the thumb. If you have deficits in the ulnar nerve, you won't be able to perform that action. And so if I ask you to grip a piece of paper, I will be able to pull that piece of paper out. You won't have a strong grip, and that's what's been described as Froment's sign. So that's something to think about for ulnar nerve. So not comprehensive, but those are a few ideas for each nerve. The next thing I want to describe is the course of these different nerves. And I think it's important to think about the course as we move into testing for these different nerves. So this is a little bit of a table, again, to describe at each area, upper arm, elbow, and wrist, where these nerves run. Probably better than the chart is actually the video that I made based on this chart, where I draw myself in marker the course of these different nerves, because I think it's a really nice visual to see on the body versus the brachial plexus diagram where these nerves run. And then you can kind of get a sense and have this visual in your head as you're working with patients, as you're either palpating sites of those nerves. For example, in this antecubital fossa, you can see that little mark of orange. That's where I might try to palpate the median nerve superficially, or the carpal tunnel. So those are two areas where it's nice to visualize that median nerve course, versus the ulnar nerve is going to wrap around and run through the cubital tunnel, which is more posterior at the elbow. It's going to enter the wrist at Guyon's canal, which is more medial or towards the ulnar side of the hand. So that's where that ulnar nerve is going to be. And the radial nerve, you don't catch the marker on my arm, but suffice it to say that the radial nerve is going to be more posterolateral at the elbow and then run through or deep to the anatomical snuff box. So starting to visualize where these nerves run, I think, can be helpful on an actual human versus just in a diagram. Next few slides are going to break this idea down. So here is the clinical diagram of that nerve, and then the corresponding areas that I've tried to simplify where that nerve runs. But again, I would really encourage you to watch that short video, because that'll give you a sense for these things in 3 dimensions on a human being. So median nerve, Here's a slide or a view of that ulnar nerve course and where you can localize that, and then the radial nerve. All right, so how do we test these different nerves, these peripheral nerves? Well, we tend to place mechanical stress on them and see how they respond. So nerves like movement, but they don't necessarily like a sustained stretch if they're irritated, just like other tissues that are maybe a source of pain or irritation. If a muscle is painful or irritated, it's not necessarily going to like being stretched. Same thing with a nerve. So one way that we can provoke or try to reproduce a patient's pain is by stretching or placing tension on these nerves. So these are described by different upper limb tension tests. I have videos of each of these tension tests. I don't feel the need to talk you through the wording of them because I think the videos do a much better job of describing the arm positions and the way you're going to create those testing positions. So median nerve, this is going to show the beginning of the test and the end test position, but I encourage you to watch the videos. So if you're testing median nerve, you're going to utilize this test position. Radial nerve, you're going to utilize a different test position to place tension on that nerve based on the course of where that nerve runs. And same thing with the ulnar nerve. So I'd encourage you to watch those videos just as a quick review of the different upper limb tension test positions. Those are the three main upper limb tension tests. There's also been described a secondary test position for the median nerve. I left it off just for simplicity's sake, but I didn't forget about it. I just am trying to simplify a little bit. Those are going to be the three main testing positions. All right. So one thing that's important to mention is that with these upper limb tension tests, what constitutes a positive test? So a positive test is reproduction of a patient's symptoms. Usually this will be some sort of neural symptom description. So numbness or tingling, a paresthesia, burning or a shooting pain, like we said earlier, is indicative of a neural pain tissue generator versus musculoskeletal pain is more often described as achy, sharp, dull. Asymmetry on the right versus the left, so significant asymmetry in upper limb tension testing. You always want to test left and right. So for the left tension test, you get much less range of motion at a specific joint. That could indicate a positive test. Sorry, I just noted a typo here. Apologize for that. And then structural differentiation. So ruling out a muscle or other tissue as a cause of symptoms is going to be important. So this structural differentiation, what this looks like is once you provoke symptoms, this looks like either taking off tension or adding tension to the course of that nerve. And one way you can do that is distally, either flexing or extending the wrist, depending on what nerve you're testing, or you can do it proximally by introducing a head side bend. So usually if we think of side bending to the ipsilateral slide, that's going to reduce tension. Contralateral side bend is going to create more tension. And if that changes symptoms, then you can be more confident that's a neural issue and not a muscular issue. The other thing you can utilize are these nerve glides or active range of motion upper limb tension testing. I'm going to fly through these because we don't have much time left, but start position is the same for all of them, so cover your face. And then the end position is just the position of tension for these different nerves. So for median nerve, you're going to have elbow extension, wrist extension. For ulnar nerve, you're going to have that elbow flexion, wrist extension. And then radial nerve is going to be this elbow extension, wrist flexion, kind of looking back position. So those are also some ways that you can actively test those nerves. Here are references, and thank you for joining me for some neurodynamics of the upper extremity.